right, well, good afternoon. Welcome, everyone. My name's Kate Bunting. I am on the SID-US board, and right at the moment I have a consulting firm that I work at, but thinking about Sylvia's introduction this morning and about what was I doing 30 years ago, and I was thinking, wow, I was working at CARE. My focus was much more on global health. Through the years, I've worked in a number of different places, and but lucky enough today to get to moderate this panel with some of the most preeminent global health experts that we have around town. So this conference today is, focusing on the topic of inclusion. I think we all can sort of relate to that. Sometime in your life, I'm thinking that you felt unincluded, and what that meant to you in that situation. Today, this afternoon, we're going to talk about health equity and sort of how do you make sure that everyone is included in health systems. And as easy as that sounds, I think it's a lot more difficult in practice, but we're going to hear a little bit more about that today. Promise to ask a couple of questions of these guys, and then a little bit later we will open it up where you can stand at the microphone and we'll try and take some Q&A. I've been instructed, since we started a little bit late, we can go as long as 2:55, as long as my guests are willing to stay. Great. So with that, let me introduce the guests that I think probably need very little introduction. But with us today, we have Natasha Bilmoria, who is the Deputy Assistant Administrator for Global Health, sits upstairs. I think we've probably pulled her away from some other major global health crises. She was that person who walked through the door when she got her job in the Biden administration, and like the whole world was on her shoulders. Like, just go do it, okay? So she had a great staff, obviously, but that was a lot to juggle. But any of you who know Natasha know she's been in and out of this ecosystem at places like Gavi and the Friends of the Global Fight, sorry. And Dr. Jen Cates, again, if you've spent any time in the last couple decades around this town, you know that Jen is the person that you go to as the VP of Global Health at the Kaiser Family Foundation. If you want to know something about trends or insights or what's going on in health, or how something being looked at, that's who you rely on. So I'm really excited today to have them both with us, and we're going to have a fairly casual conversation, and then we'll move on from there to the Q&A. So I guess just maybe to start off with, Natasha, I'll go to you first. When we talk about health equity, I know there is, there's a lot floating around there about this term. There's a lot of, buzzwords today in terms of health equity. Can you tell us a little bit more about where USAID is looking at that issue in terms of health system strengthening, and sort of, what's the vision and the focus right now?
Sure. So I'm going to follow the rules that I was given to speak into the mic. So first of all, Kate, I just want to say thank you, and to Jen, and it's really nice to be with all of you and see some very familiar faces in the audience. So, I think the term equity is, as you said, it's something that we're hearing a lot of, and I think in a lot of ways there are a lot of different contexts in which we talk about equity, but I actually think they're all very important. But when I think about that term, I think it's a pretty simple principle, which is that all people should have the opportunity to achieve their health potential. And I think that is a belief that is fundamental to the work that we do in the Bureau and in the agency writ large. I think at the most basic level, health equity is really achieved when people they need health care, they have access to quality health care, and they get it in ways that they can trust. And I think that goes for everyone, regardless of their social economic standing, their gender, their sexual orientation, their ethnicity, et cetera. And I also think, when you think about health equity, what is the counterfactual to that? So what happens when we see health inequity? And I think what we see is not only a negative impact on the individual, but I think it has significant impacts on, you know, economies and society, and it is something that really stretches beyond what we think of, you know, just being health outcomes. And so I think it really is critical that, you know, we think about this. And I also think that when we look at health inequity in the eyes of COVID, I think it was, you know, I think it was something that just became very clear. And we saw it in this country too. And so I really do feel that this word of equity and health inequity was probably the biggest weakness that we saw in the pandemic, and I think it highlighted what we really need to do, not only globally but within our own countries. And I think we saw that kind of inequity, you know, globally, within the United States, within rich countries, and I think that it's clear moving forward we've got to make progress on that.
Great. And Jen, I know sort of as the outsider to USAID, you probably have some of your own thoughts about health equity. I think you've written about it once or twice, maybe.
A little bit.
Anything to add?
Yeah, I also first wanted to say hello to everybody. It's great to be here and to be part of this conversation. You were talking about 30 years ago, so as someone who also has been working in this field for at least then, you know, equity is not a word we used to use when we talked about health. And so, you know, it's great that we've embraced that concept, and it is you know, it's common to hear it now. But that also has a risk, because I think the risk is that it's not always well defined, and it becomes a buzzword, and, you know, could risk actually not achieving meaningful action to make equitable decisions happen. So a key concept for me in thinking about equity is, and this is where I think it gets hard for program implementers, policymakers, and others, is that it's not about equality. It's not about giving everybody the same thing. It's about assuring that everybody has the same ability to access the same things. And what that actually means is that you have to make very deliberate and different kinds of decisions around resource allocation, around program design, and that's uncomfortable because it really is about taking the existing framework in which we operate and adjusting it. And we're not good at it. We're not good at it in the United States. We're not good at it globally. And certainly COVID has challenged everybody to do that. I think there's been some great examples where it has worked and others where it's been tried and it's still an uphill battle. But for me, I think the concept I just want to make sure we all, or I think is important to have at the forefront, is this idea that equity, it does require work to get there, and it requires thinking about allocation of funding, allocation of programs, literally where they're placed, what they look like, who is delivering those services, what it means to enable somebody to access them. We have to look at that quite differently.
Great, thanks. And I guess in terms of equity, I think, Jen, you just gave us some examples, but Natasha, from your viewpoint, is that a specific set of programs, or do you have some examples of some of the stuff that USAID has been doing on health equity?
Sure. So I think, let's start with COVID. I think that's probably the area everybody in the room is, very familiar with. And, I think that when I started, the vaccines were just becoming available in the U.S., and they were not available in poor countries. And that also went with therapeutics, diagnostics. None of this stuff was really being provided in the way that it needed to. And I think as we started seeing early, probably first and second quarter of last year, starting with India, there was an explosion of infections in different parts of the world. And I think, we were very lucky to have, a pretty significant amount of funding from Congress to work on the global response. And I think in aid, we really took that incredibly seriously. We have spent billions of dollars to help close gaps in vaccine access, and not only in the doses, but also now really working to ensure that once those doses actually show up to a country, that we have the ways to support countries in getting those shots into arms. But it was also around oxygen, it was around other therapeutics, it was around PPE, and these were things that countries didn't have. And I think we really worked hard to ensure that people had those interventions that they required. And I think, again, when you look at the equity, inequity piece, I mean, all of these things were available in rich countries. And although I think it is fair to say that even in rich countries, again, there were inequities to access for many of these things within countries. But, a lot of these places just didn't have access to the, kind of basic things. And we have worked really hard to at least support as much as we can to do that. And more needs to be done too. But that's an example I would provide.
And before I go to Jen, I guess I just want to sort of harken back. I know health equity is just one part of your vision around health system strengthening. And I just wanted to understand sort of a little bit more about the overall view of health system strengthening before we delve into some more details and onto COVID.
Right. Well, so, and I'm happy to talk about this as the conversation goes, but, we put out a really, I think, seminal vision in March of last year, and the author happens to be sitting in the audience right now. But, and what that report really did, in my view, was, we talk a lot about health systems, and, I've said this to a number of people recently, that I think when we talk about health system, there's a lot of eye rolling that goes on because people don't really understand what it means. And I think what this report really did was really make sure that we were shifting our thinking. And again, we talk about health systems as it relates to certain disease areas, and all the global health work we're doing does support strengthening health systems. But I think what the vision really does is look at it in a very cross-cutting way, and how do we, there's some key areas that really need to be strengthened in order for the entire health system to be strengthened. And I think that's really what the vision goes into, is what are those broader cross-cutting areas that really need to be, that countries need to focus on, that, there needs to be continuous and consistent investment in, and that's really how you get to a broader, stronger overall health system.
Okay, great. And then just in terms of health equity, Jen, you sort of, referenced the idea that this isn't an easy thing, and I guess, you have to make decisions. And I know you have some examples perhaps from all of the studies that you've done that might illustrate a little bit more of some of the kinds of decisions that had to be made. And I guess, they could be COVID specific or, any other health example, but we'll eventually kind of narrow in on our COVID discussion.
Sure, yeah, no, I actually want to start with another example and to try to connect it to the role of health equity and health systems and how they work together. And, a lot of the main architects of the COVID response mechanisms, ACT-A and COVAX, actually came from the HIV world, where I actually have focused most of my work historically. And there's a clear example where rich countries had access to treatments in the mid-1990s, and poor countries didn't get those treatments until about 2003. And the gap in that time is, we can at least say COVID hopefully will not have that big of a gap, but it's a huge gap that resulted in actual lives lost, life expectancies dropping, very significant health impacts. And there's a lot of advocacy and other efforts to change that. But when finally the forces aligned and there was a decision to begin to respond and provide antiretroviral therapy in sub-Saharan Africa and in other countries around the world that were low and middle income countries that virtually had no access at all to antiretrovirals, or very little, That was when that decision was made with PEPFAR, when that decision was made with the Global Fund, what had to happen? They actually had to invest in the infrastructure to deliver those medications. So we always think of these as like very vertical interventions, but actually in reality, to get antiretrovirals to actual people, it did require this rethinking the delivery, creating a system in some cases to strengthen the health systems. And we actually just did some analysis looking at trying to understand, did PEPFAR have any spillover effects, positive or negative, on the health systems, in which it obviously supported to some extent, but was very HIV-focused initiative. We actually did find that PEPFAR, as an example, had lots of positive spillover effects on maternal and child health outcomes, not HIV specific. So just to kind of connect those two. But in the COVID case, the last couple of years, in addition to looking at some of the global equity issues around COVID, I was able to focus on some of the inequities within the United States, and which there are quite a number of them in terms of access, and everything from who got exposed, so individuals who were unable to not work when many of us could stay home, individuals who had to take public transportation, who faced lots of barriers and without social supports to allow them to be safe, and then became exposed more regularly in the work environment. And then when it came to getting vaccines to various populations, there were a whole range of inequitable challenges, but there were some, I think, positive examples where different jurisdictions really tried to address this. And a few examples that stuck out to me, one was when it came to the initial phase of vaccines being available in the US, just like everywhere else, we were basically rationing a life-saving intervention. And how do you do that? Well, one way is you just sort of let everyone come to the door who can get there. Some jurisdictions said, we're actually going to set aside a portion of our allocation, 20% or 10%, for people that live in certain zip codes that are lower income zip codes. Or we're going to set aside a portion of our allocation for disadvantaged populations. So that was one method that I think is very interesting to consider. Another was there were a whole round, if people remember, there were all the eligibility. I think, you're eligible when you're in this group and not in that group, and you have to wait. Some jurisdictions actually changed that a little bit and said, in addition to the standard groups that CDC is recommending, we're also going to let others come to the front of the line. And then there were other things like where vaccine sites were located in communities that made them more accessible, who was delivering the vaccine information and actually vaccinating. And then finally, things like, taking vaccination to people's homes, where if they faced multiple barriers to leaving their home and couldn't get to a vaccination site. So there are changes like that can be made, some of which are border on like structural change, but it's not generally how things are done. And it did require rationing in a different way than I think, all people expected or wanted, because if you do remember, there was a lot of clamoring to get that vaccine, and people were upset, I think, when lines were changed. But in some cases, you have to do that to have an equitable outcome.
Thanks for that. I will jump in wearing one of my previous hats as the CEO of HelpAge, which was an organization working with older people around the world. We were quite pleased to see that probably for the first time in history, older people were prioritized in this pandemic because we did have information that was going to impact them. Trying to get the development community to prioritize older people in other health ways is another whole set of story. But so Natasha, I'll maybe pitch to you, time machine, if you could step back 2 years, 3 years ago, what would USAID have done differently, or are there any lessons that you guys have learned? And as Jen pointed out, it seems like there's also some positives that have come out of this.
Yeah, well, it's funny, I was doing another talk a couple of weeks ago, and it was, again, as often when you talk about COVID, it's a lot of the doom and gloom and challenges. But I think that, I do think that one of the things that has been an incredible opportunity out of this is because these weaknesses have been so exposed, and in order to get the immediate COVID responses out, we've had to deal with those challenges. But I think what we're actually starting to see is when we're putting out these interventions, so let's use vaccination as an example, we as as a government, but really as a world, when we think about vaccines, we usually think about routine immunization for kids, right? And, under 5s, and, even when we're thinking about adolescents with HPV, again, but they're younger populations. And in this case, we were, really going to, moving towards adult vaccination. That was where we had to focus at the start. And so I think as we have been doing that, we've learned a lot. Jen talked about the barriers that, whether it was vaccine hesitancy or, who is the person giving you the vaccine, that matters, who's talking to you about it. And I think there have been a lot of things that we've learned from this experience. And those aren't just going to go away, when COVID becomes more endemic. I mean, we're actually going to be able to use those systems and processes for a variety of other types of health interventions. And so, I think that that's one thing that I think has really been an opportunity, in that in order to get all of these interventions out as quickly as we have, or had to, we've actually been forced to, really work with the systems that exist, but ensure that they're usable for these other types of work. And I think that will continue to support, other important health activities, whether it's TB, MNCH, family planning, et cetera.
So similar to Jen, what you were pointing out about PEPFAR and the HIV process of setting up all of these health facilities that somehow helped.
You hope that it
You
will,
hope.
will have a lasting effect. I was going to say something about something also that's positive. While it may seem that there's been a lot of frustration in COVID in terms of getting new vaccines and new interventions and other medical countermeasures to actual people, the reality is the lightning speed with which those have been discovered, produced, and actually getting to people all over the world is quite unprecedented. And I think we have to hold on to that, and it's a good lesson that we can do things differently. It required a lot of doing things in challenging basic systems of how we operate, and I don't know if the norm will allow for that, but I think it shows that a lot of times people would argue we can do it better, we can do it faster, but there wasn't sort of the proven concept. We've proven the concept, it can be done, and so I think that's something to hold on to and try to keep in the system, for sure.
And I would just say, even looking at what Jen just said, even moving into the therapeutic side. So, we have, new antiretrovirals or retrovirals that are really saving lives, and they're abundant in rich countries, and and they're new, but we are now working, again, within a pretty short period of time to move to get those therapeutics into poor countries, and that is actually going to be in some ways harder than vaccines, because the process that it will take to ensure that the systems are available, to get the drugs to pharmacies and all of that, it is going to be a more challenging process in the developing world. But again, the fact that we're taking it on soon after it became available in resource rich countries, I think is a good sign of how we can continue to do that.
And in terms of it being more difficult, that's, I presume, is going to sort of go back to how strong health systems are and sort of what their ability is on logistics and
That's right.
that type of thing.
Right.
And maybe Natasha won't say this, but also additional funding would be a factor that might play a role.
Just
I'm
a
happy
little
to
bit.
talk about that.
Well, we can certainly go there later on in the discussion. I think for most of us, we all know that, having resources certainly makes things easier. It also probably makes things a little crazy when you walk in and are suddenly dealing with a new pandemic and trying to make all of these things happen. I guess, maybe before we jump in terms of the path forward, Jen, you just mentioned something a little bit about technology. I know I've heard of things like the unmanned aerial Drones, sorry, thank you. Are there other things in terms of technology that are contributing to, helping address some of the health inequities?
Yeah, certainly. I mean, technology can be good and bad depending upon how it's being used and how accessible it can be. But there's plenty of examples with COVID leading to just the necessity for technological solutions in areas in health where there was resistance before or lots of barriers to doing so. And telehealth is probably the one that everyone knows the most. But that's not just happened here. I mean, there's lots of examples of telehealth or some kind of other kind of connection between health provider and individual patient in some new way that when you're desperate and you can't get to people, that's what you can rely on. And I think there's a lot of successes there. It doesn't work for every scenario and it doesn't work for every population, but it has the data that are starting to come out show that it has created more access for people that might not have had it before and certainly wouldn't have had it in the sort of heavy lockdown period. So I think that, we have to learn from that and try to understand where we can keep using it in our regular programming. And so we've leapfrogged over some of those barriers and now it's sort of up to everybody to kind of figure out how to make it work more broadly. I think that's probably the best example.
Yeah, and I think there's been a lot in COVID, but I'll even kind of go back, in my last position at Gavi, there was a lot of work being done using cutting-edge technology to expand routine immunization and really actually utilizing that to reach the hardest to reach. I think you can. Almost everybody has a cell phone, right? And so, there were projects working with healthcare workers where they were, their phones really served as a way to ensure people were, if there was a new mom, ensuring that, they had, the key things that they needed after pregnancy and ensuring that kids were going in for their immunization. And so, I do think that there is a lot of technology out there that can be used to strengthen the work that we're doing. And again, ensuring that we're able to reach the hardest to reach in that sort of last mile part of things.
I have one other that I think is interesting. Yeah. It's related to technology, but it's data. You can't, it's hard to understand equitable allocation or equity, the impact of equity or inequities if you don't have good data. And we certainly still have a lot of data challenges. But the sort of light speed again at which even, UN organizations, our government and other bureaucracies made open source data available as quickly as possible on the internet that would never have happened before. I think that's a good sign. That's not going to stop. I think that has changed the outlook that you can put data out there, you can make it available. It's not perfect, and we have plenty of critiques of it. But the amount that is there now compared to just 2 years ago is pre-COVID is kind of amazing, and I think that's something we should harness as well.
No, that's a really great point, and I guess to kind of segue on that point. I think data might be something that you know a little bit about. And, I just thinking, I think you and I had talked about this before, but one of the challenges sometimes is, when you're talking about health equity is making sure you are actually counting everyone. And we're a really data-rich country. We have a lot of information. I know sometimes that's a struggle overseas in some of the countries we work, but I didn't know if you had some stuff you wanted to maybe share and some of the data that you've seen. And
despite what I said, it's still been a really big challenge. And so if you want to try to understand how vaccines are being allocated within countries, low and middle income countries, it's really hard to get that information. We can look overall at the country percentages, and there's some estimates to say like what share of healthcare workers might have been vaccinated, but the sort of granular information you'd want to understand who's most at risk, are they getting vaccinated, is just not available. And that's very frustrating, and it doesn't make allocation as easy as it could be. Even in the US, one of the areas that myself and colleagues have worked really hard on throughout the pandemic is to try to better understand whether people of color are getting access to vaccinations and at what rate. And the data have just been very, very hard to obtain, so much so that we had a whole team that was going to every state dashboard or website every week pulling data individually to try to understand what was happening because it wasn't coming from the federal government. So that really, just shows you we have a long way to go, I think, in this area, here and everywhere. Yeah.
Great. So we kind of started down this path, but why don't we kind of move more towards the idea of, in terms of the lessons learned and where we're going. What does the future hold? You guys have done a lot of looking at the pandemic and, sort of getting through the main part of the crises. There's always something else coming down the pike. But, in terms of, I guess, starting with you, Natasha, going forward, what do we have to see from USAID?
Yeah, so I think that the first thing is that I think we have to acknowledge too that people, whether it's here or anywhere in the world, I think people are tired of a lot of this. I think that we've all, if you think about what we've all experienced over the last 2.5 years, it has been a huge amount of absorption of a lot of negative things. It's death, sickness, economic and societal loss, and I think it's been a huge drain on people. But I think, from my perspective, as I look at what we've done and what we've seen over the last 2 years, but also looking at the work that really has been done to strengthen systems over the last decade. I think what we really have seen, in my view, is why it is so important to consistently, for countries to consistently invest in strengthening their systems. And it's got to be something that is done, in the broadest of ways, and in a lot of different places, whether it's, financial resources, whether it's data collection. And I think that strengthening needs to continue. And the whole idea in all of this is that you've got systems that can then manage these shocks when they come, right? Okay. And I think that, in my view, is something that is a big part of the work that we're doing in the Bureau, is to really ensure that systems are able, in those times of non-crisis, are getting, primary health care out, that people really do have access to the basic health care that they need in a quality fashion, but that when these shocks come, and they will, that one, they're able to tamp them down, but they're actually able to then respond in a way that, again, the system doesn't completely break down to deal with that outbreak or whatever it is that's happening.
And Jen, from your viewpoint, do you see, future challenges? I know that's partly what you get paid for, but what kind of challenges and what kind of opportunities are you seeing in sort of the next iteration of health systems, and as we maybe move into a world that's less pandemic focused?
I think, as Natasha was saying, we're all tired because we've had a front seat in this experience, and seen up close and personal what happens when there's inequities out there, what happens when health systems just aren't what they should need to be. So probably for the first time since I've been working in global health, there's a collective recognition of the importance of investing in systems and in public health infrastructure. So that's good. I think there's consensus around that where there hasn't been, and the eye rolling that you used to get maybe is not going to be as much of an eye rolling. Does that mean we're going to do things differently? I don't know. So that's where I get a little worried. But there is momentum, and I think the proof will be, or we'll see what will happen with all of the discussions going on right now on the future of global health and the future PPR mechanisms that are going to be put in place. To what extent are they able to, at the same time, have indelible changes in health systems that reach everyone, and how much will equity, in the sense that we've been talking about it, really be featured in those discussions? I mean, one of the things that was kind of an amazing intervention that Natasha referenced in COVID was COVAX, and the idea was that everybody should be able to get access to vaccines. Well, I think we all underestimated, or maybe we didn't have a chance to sort of question it because we had to move full speed, how selfish high-income countries were going to be. And so it kind of undermined that concept, but the concept is a good one. So what can we do going forward so that that kind of approach is right-sized and can work for everybody in the future?
And I totally agree with that. I mean, I think, when we were talking the other day about this panel, I mean, it is actually really interesting to think about. It really, I mean, we've all been in this world for a long time, and I think it's really the first time that people came together, at least in theory, to think about, everybody was going to need vaccines, right? Mm-hmm. And we think about COVAX now as, the mechanism that is providing lower income countries with vaccines. But I mean, let me be clear, when it was first put together, and I was part of that, it was a way for rich and poor countries to have access, and the way they paid for it was different. But and it's obviously turned into something different. But I think, as Jen said, it is going to be really interesting to see, given everything we've all experienced, what is going to be our way forward. Are we going to remember that we are incredibly interconnected, and we have to ensure that everybody has a seat at the table? And I think it's also really important for the countries that have always been seen as the one getting the aid are also very vocal about being at the table and participating and having a very equal voice.
Yeah, it seems to me it goes back to the conversation of inclusion, and I think we've learned a lot of lessons from the countries in which we work about they came up with a lot of solutions in terms of how are we going to get this done, how are we going to get it out to people, who are we going to mobilize. I think I want to reference back one last round and then begin to look to questions from the audience. But I was just thinking, Jen, you were talking about all the work that you've done on HIV, and certainly Natasha, you as well. There's a lot of parallels, I guess, we can draw in terms of COVID and HIV, in terms of it, really being sort of a pandemic situation, people being, nervous about it. We've, learned a lot, but I think what I'm hearing is that we're hoping some of these lessons may spill over into all of our every other day, interchanges with the health system, that it shouldn't just be when there's a pandemic. And I didn't know if there was anything you guys could add to that, or if I missed something in this conversation that you really wanted to say.
No, I think that's right. That's the hope, that lessons learned and things that are done differently now do continue, and not just for pandemics, but for how we deliver and think about getting health to everybody. I think what I think all of us worry about is when we look at the HIV example, what happened over time. Those who were left out in the beginning are still left out, and so we don't. That's a real risk with COVID, and that's likely what we'll see in a couple of years, where when things are endemic in certain countries, we're just not going to be having the urgency that's needed. So that's the downside, but I think there's at least the hope of, since we all had this front seat, of implementing some of these things for the long haul.
Yeah, and I mean, I would agree with everything Jen said, and I think also, as we've sort of intimated throughout this conversation, is that we're really at a pivotal time. I think, the issues around equity, health systems, primary health care, universal health care, these are all things that have been talked about for a long time. But I do think that this is the moment to seize it, and really, while it's still fresh in people's minds, is to really start pushing these ideas about, how do we ensure that people get access to basic health care when they need it in a quality fashion and in a way that they can access it. And I think it's about, again, taking all these challenges, but really, like I said, using this moment to really try and push some of these, really important agenda items. At least they're not going to go right over the finish line, but at least to really start them and start showing a proof of concept about how important these things are.
Yeah, and I think that obviously relates to, we talk so much about the pillars that we all work in and, how do we begin to integrate those together? And it seems like, this might be our path towards getting that done. I'm going to reserve the floor for you two if there's anything else you want to add, but also see if there's anyone who has any questions. Great. Step up. There's microphones. And just line up. Okay, just a few. I'm going to try and take like two, three questions at a time. So please tell us who you are, where you're from. Try to keep your question brief. Let's not make too many points. Let's ask questions because these guys don't always have tons of time.
Okay.
Go ahead.
Thank you so much. I'm Susanna Wupong Calvert from the Foundation for Family and Community Healing. And it seemed like along with the pandemic, another vulnerability was exposed, and that was this underlying mental health crisis. That doesn't seem to be getting quite the attention that the pandemic did, though it seems like it is just as pervasive and viral as an infectious disease, given mental, emotional, and relationship, frailty affects all of us. So and also given that we know that prevention just so pays for itself manyfold, is this the time that we actually start paying more attention and prioritizing preventative measures and helping people, individuals, families, and communities be more resilient with their emotional, mental, and relationship health?
That's a great question. I'm going to ask you to go also.
Sure. My name is Rahul Shah from Sattva Consulting, a Indian-based consulting and implementation firm. Wanted to understand what are some of the innovative public service delivery models that you all have been seeing to enable access at that last mile? Like, in India we have, ASHA workers and the digital health mission and things like that. What are some of the other innovative service delivery models you're seeing globally?
Okay, let's take one more and then we'll do some answers.
Yes, I'm Dr. Chloe Schwenke from the Center for Values and International Development. I know some of you already. It's good to see you again. We've heard from you about health systems equity and that it requires strengthening in finance and technology. But as an ethicist, and we're an organization of ethicists and bioethicists, we're very concerned about what drives the will to make that change happen. And that change is not going to happen until certain attitudes change, that certain people's dignity is respected. I'm an openly transgender woman. 15 years ago, when I tried to get medical assistance in this country, in this city, I was turned away again and again because that's where the attitudes were then. This is not an uncommon situation around the world, not just for my demographic, but for people of lower caste, etc. Where is the moral messaging coming from USAID, is my question.
All right, those are some tough questions. So let's start out with Suzanne's question, was around the mental health crisis and what can be done. How do we jump forward?
I'll start with that. I completely agree. I mean, I think, mental health has long been, underfunded, not focused on, and people just have suffered. And I've always suffered. And I think what COVID has exposed is, first of all, it made it worse. I mean, the conditions of stress, crisis, losing people, being afraid of losing your well-being, your family members, being isolated. I mean, all of the things that we all experience for somebody who is already having a mental health crisis or challenge, that it could be exacerbated, and for many people who might not have been. I think on the positive side, there has been more attention to that. There's been, certainly it's been reported on. There have been lots of studies of it, more so than I ever recall seeing, because prior to COVID, I think it was very episodic. Sometimes there'd be some attention to mental health issues. Will that change? Do I think this is the moment to take that on? Of course. And there's actually been some new funding for it, but will we as a global community really embrace what that means? I don't know. I think I would like to see that happen, because I think it also is part of achieving equity, is understanding that people who don't get their mental health supported and aren't healthy all around are not going to be able to access all of what they need. So I don't have an answer, but I agree, and I think it's something that I hope can stay elevated as we move forward, and at some point are not in a crisis at the moment. So
Yeah, and I think on our side, I mean, this is, again, I think mental health has always been, you know, a part of the work that we've done. But again, I think the COVID pandemic has brought that out. And especially, you know, there's been a lot of attention around the mental health of healthcare workers. And again, speaking about, you know, what, you know, the crisis of healthcare workers that we've seen in this country has, you know, is just as bad in the countries that we are working in. And I think that has been a really important focus because, you know, after years of going through this, and again, we already have a shortage, it's critical that we are ensuring that the folks that are providing the care are being looked after in that way as well.
Yeah, and I imagine it's fairly challenging from USAID's point, just, you know, knowing how we know how much your budget is earmarked. So, you know, trying to, you know, do something that's holistic and wrap around, sometimes you really have to do some gymnastics to be able to get that into the right funding tranches. So we had another question about innovative public service innovation, so.
Yeah, so, you know, I think there has been, you know, a lot of that, and really also looking at kind of the partners that we work with as well. You know, I think that we, and again, I'm going to speak more broadly, that in my experience, whether it's been at AID or, you know, in other organizations, I also think it's important when we think about service delivery is, you know, also thinking a little bit out of the box. And, you know, you brought up drones, and again, you know, I think it's also about balancing what we do, because I think there's always the shiny metal object that people get very excited about. But I do think the service delivery piece, that's also a really important way to get other stakeholders involved. It shouldn't just be governments that we're looking at, but who are the groups, companies that are working in the field that have the ability to reach the last mile in ways that, you know, one sector could not do it alone.
Jen, did you want to add to that one? No. Okay. And I'm just trying to rush us through so we can get to a few more questions. And Chloe, as usual, very articulately talked about, you know, it's great for us to talk about all these things, but really, you know, how do we make people feel included? Who's going to really push this moral question?
I mean, I think that's a really important question. And, you know, again, I think what I said at the beginning was, if we're really talking about health equity, it is the ability for people to get the care that they need at the time that they need it and in a way that, you know, they trust. And that's regardless of, you know, all of the things that, you know, whether it's social, economic, gender, sexuality. And I think this is an area that requires continued effort. And, you know, I think we are dedicated to ensure that that principle happens. And you know, it's going to take work on everybody's end, but, you know, it is something, in order to achieve that goal, we've got to look at those issues in a very direct way.
I want to add one thing, because it's a great question. I think the will is not usually there, and it's where in sort of the development space, donor governments such as the U.S. can play a really particular role diplomatically in how they're conveying this to other countries. And some administrations do that, and some don't. And certainly it's a challenge when we have places like Texas that are doing the same thing that you experienced 15 years ago to young kids. So, but the sort of moral angle is one that the U.S. government really can champion, and hopefully will in some of the broader discussions happening with the sort of next, how we're going to finance the next pandemic. So hopefully, I share your concern, but I think there's a lot of opportunity there.
Great. Let's take two more quick questions so we can wrap it up.
Thank you. First of all, my name is Dr. Priyanka Brunesi. I'm a researcher at Purdue University. And I wanted to understand the role of private sector engagement as we move forward. This pandemic really showed this, like you mentioned, the cross-sector, having all the stakeholders, especially private sector, play a really important part, especially in the accessibility and the quick response that, COVID required. So as we prepare for that next pandemic or whatever the next challenge, how is USAID kind of planning on engaging that private sector in the future?
Great. And I was not equitable. I think I did twice there, so I'm going to do two quick questions here.
I just took a little bit longer with my question. My name is Huiling Pan. I work in health policy and financing at Palladium. So my question is actually going back to that moral, who should do this? In a democratic society, priority setting and resource allocation should not just be a technocratic decision. It should have some space for society to weigh and debate, what they care about the most. In the case of COVID, for example, with vaccine allocation, in the beginning, the international health technical community was quick to push out guidance on prioritizing healthcare workers first and then essential health workers. But then what happens after that when you get to that middle stage when LMICs have a little bit more supply of vaccines but not enough, and it was left to them to decide what to do. I felt like it was a missed opportunity because they were looking for guidance like always. So my question is, how can people working in international health in this technical space contribute meaningfully to that and not replace that democratic process? Thank you.
One more, if you can be very brief.
Thanks. My name is Kate Parsons. I'm a recent graduate from American University's International Development Masters, and I did my thesis with an indigenous health rights organization in Guatemala. One of the things that they said to me was, to us, a right to health is not a right to a hospital. It has to do with their respecting and incorporating their traditional medicine and practices. So my question is, what does health equity look like when a community's priorities go beyond what we might be familiar with as Western medicine?
Okay. And does anybody want to jump in on any of those?
I want to start, I'll
Yeah.
start on the second one around this issue of, making technical or decisions based on really technical considerations or medical considerations about how you prioritize and not necessarily taking different viewpoints into that discussion or even thinking more how to provide guidance to countries. I don't know if this is, the exact answer you were looking for, but this is where I think, and I'm not sure we have done a great job of this in COVID, but this is where having civil society and community groups at the table, not just listening to decisions that are being discussed, but actually informing them can really, really make a difference. And also having some of the countries that we're talking about at the table, which everyone was moving really quickly, and it's already, others have critiqued this, but the Global South wasn't really part of some of the big decisions that were made, and communities certainly have fought to be involved, but have not easily been part of that formal decision-making process yet. I think it's changing. But I think those are the kinds of things that really can inform those decisions in ways that are more democratic and actually can lead to outcomes that actually work for communities and provide the right kind of guidance that people want.
Okay, that's our cue to be quick.
So I'm going to answer, just quickly answer on the private sector. So I think that it's a really critical part of the puzzle, and I can say I've been at AID for a little over a year, and this is, there is quite a lot of work going on with the private sector. We are not the easiest agency to work with if you are the private sector, and we've heard that loud and clear. But at the same time, I think, again, using the example of COVID, there has been really great opportunities to work with the private sector, and I think a lot, we've seen some of that or come to fruition as far as the, some of the announcements that have been made in the two presidential summits. There is work going on the global, there's something called the Global COVID Core, which is really looking at, a number of different countries companies that are using their workforce to actually go into countries to support, some of the things that we've been talking about. And I think, what COVID has shown us is it's really about, I think a lot of companies want to do something, but it's figuring out how do we partner with them in a way that I think has, a much longer term impact. It's not sort of like flying in because there's a crisis and, there's a time and a place for that. But how do we, again, when we look at equity and strengthening systems for the long term, it is not just the role of government. It is a role of, a number of different stakeholders to participate and support that work moving forward.
Trying to make interactions less transactional, any kind of partnership always takes time to develop. I'm going to make a leap here and on the equity question about indigenous cultures and say, just from my standpoint, my experience, that it is a lot about talking with the people you're working with and trying to be patient-centered. I don't know if either of you want to take that on or do any more, because we are really over time.
Just very quickly, I think outside of
great
the
question.
COVID, I think in lots of health, there's lots of health examples where when it's really worked, it's because it's involved the community and how the community conceptualizes of health, which is different around the world, obviously, and you did your research, you probably know this more than I do, but I think that is where you can really create much better opportunity for equity and access. So to not do that and to think of it very stringently is certainly not going to get you there.
Okay, so my conclusion is just going to be that that health equity is making sure that, everyone can enjoy their best potential in terms of health. We talked about a lot of things. We talked a lot of lessons about COVID, about data, technology, and sort of the needs for health system strengthening. I want to thank our two panelists who were, happy to come here and be guinea pigs and just sort of throw it open and have a good conversation. So thank you very much.
Thank you.